a question from Ryan about what's the problem with that? Why are we often, as clinicians, hesitant to treat small multiple bleeds with probable underlying tumours? What's the problem with that, and why do we often recommend delayed imaging, for example, waiting 6 weeks for the hemorrhage to resolve and then going ahead with the treatment? So perhaps I can start answering that, and then anyone who has any comments. I suppose the thinking I would have about that is that when you have an area of hemorrhage, so bleeding, it can be difficult to see the extent of the tumours underlying it. So it's true that if it's very small, that you know that there's a small volume there. However, it's difficult to target that accurately. And it may be the case, as we sometimes see, that once the hemorrhage resolves, that there is no evidence of viable metastases underneath it. And so, in effect, you'd be treating something unnecessarily. I don't have any data for this, but also Gamma Knife is it's a powerful tool. The radiation is powerful enough to kill those tumor cells. That's how it works. And so irradiating a region of brain that has hemorrhaged may have some risk associated with that. So what we don't want to do is aggravate that area of hemorrhage and cause a further hemorrhage or side effects associated with that. So those are kind of thoughts I have about why we might not treat an area of acute hemorrhage. I don't know whether anyone else has any thoughts in addition. Any experience with that?
Kieran, I think you're right. If you've got a larger lesion, then you certainly, and if you wait a while and the hemorrhagic portion is reabsorbed and there's no viable tumor in there, then that's great. I have read a study, I can't quote it, showing that radiosurgery does actually protect against further hemorrhage. I know there is some reluctance by some clinicians to treat with radiosurgery, but you know, the best thing to do is treat these lesions because then they won't hemorrhage.
The next question is, do we have any experience of neoadjuvant SRS? So perhaps this is one that I can start to address, and anyone can jump in who wants. So we certainly do have experience with that. It's not our routine practice. Just what we mean by neoadjuvant SRS is essentially when someone has a metastases, it's treating it with radiosurgery before traditional surgery to remove that metastases. So there's several benefits to doing that. You have a well delineated volume, you can see the metastases and the border of it very clearly, so it gives you good clear treatment target. You don't have to wait to treat any other metastases for the patient to recover from surgery. However, the downside is you're having to treat a large volume and essentially treat a lot of tumor that you're essentially going to cut out and remove anyway, and the associated complications you might get from treating the larger metastases. Would anyone else like to make any comment about that? I think it's an ongoing area of research, isn't it? It's something that people are very interested in. Ian?
I think this is a really interesting subject, and there has been a study to show that actually if you treat them in a neoadjuvant fashion as opposed to treating the post-resection cavity, you're actually treating a smaller volume, which is counterintuitive, but the studies suggest that that's the case. And of course, if you're treating before resection, you're reducing the risk of leptomeningeal spread dramatically. So I think this is a really exciting area of SRS, and we're holding a British Radiosurgery Society meeting in January, a quick plug there, and that's one of the topics that we'll be covering.